for item number 4, which is the discussion and take appropriate action on legal presentation recommendation on the formation of a fundraising entity. And I do believe that we have a motion that we'd like to read to the group.
Okay. I move that the Strategic Planning Committee authorize staff and council to develop a draft foundation formation package for a charitable foundation to support Central Health's philanthropic fundraising efforts, including draft articles of incorporation and draft bylaws for the committee's review and approval and recommendation to the board for consideration and adoption. The draft foundation formation package should be consistent with executive session discussion. The draft foundation formation package should be presented at the March Strategic Planning Committee meeting.
We're going to meet in April 8th.
Okay, presented at the April Strategic Planning Committee meeting.
Yes, ma'am.
Okay, that's the motion.
Thank you. Do we have a second? It's been moved in second by Manager Kitchen and then second by Manager Brinson. All those in favor, please signify by saying aye. Aye. Do we have any noes? Any abstentions?
We're not, you can only take votes from people that are appointed to this SPC.
Oh, I thought we were now doing the whole thing. Oh,
No.
okay. Okay, I thought we were doing committee of the whole now.
No.
Still not clear. Okay, well then, are you a member of this committee?
No,
Oh,
I can make a
you
motion,
can make
but I
a
can't
motion,
vote.
but you can't vote on it.
That's
Okay.
right.
Okay, so let's go back. Motion's been made by Ann.
Yep,
You're a member of the committee. You've seconded it.
Yep.
And now Sedora, Cynthia, myself, and my Cynthia on the left here can vote. So all those in favor, please signify by saying aye. Aye. Okay, any abstentions? Any noes? No. Okay, good. We got it out. Thank you. Thank you very much. Thank you for your work. Very good work. Thank you. Okay,
good luck.
all right.
You want me to write
As
it down?
we're moving back into the next presentation will be in open
The only things that she had.
and
I know.
Were the articles of incorporation.
let me call them up.
Yes, yes, you didn't have it. Yeah.
Receive and discuss. Okay, Monica, is your crew ready? Yep, okay, we're gonna take receive and discuss a presentation on the safety net focused community health needs assessment and gap analysis. Monica Crowley, Yvonne Camarena, and JP Eichmann will be presenting. Ike Miller will be presenting.
Thank you, Chair May, and thank you, Strategic Planning Committee. My name is Monica Crowley, and I'm the Chief Strategy and Planning Officer and Senior Counsel at Central Health. And we're with, as Chair May said, Yvonne Camarena, who is Community Care's Chief Nursing Officer, and JP Ike Miller, who is Central Health's VP of Strategy. And we are very excited to present to you today an update on the development of our first joint community health needs assessment, otherwise known as a CHNA, a new collaborative effort between Community Care and Central Health. It has been 4 years since Central Health last developed its safety net focused community health needs assessment, and 2 years since Community Care's last assessment, making now an ideal time to refresh these documents. Our joint community health needs assessment will focus on the safety net population of residents living at or below 200% of the federal poverty level. This focus on the needs of our low-income neighbors is the difference between our joint CHNA between Central Health and Community Care and the city and county's CHA-CHIP process and other local needs assessments, which we also participate in. We are in the process of selecting a vendor to support this assessment, and we are very excited to have Yvonne with us tonight and to get this work done with our partners and friends at Community Care. And I'm going to hand it over to JP to provide some more details.
Good evening, everyone. Today we are going to provide a brief review of poverty in Travis County, the scope of our upcoming community health needs assessment, how we are aligning this work with community care and other partners, the deliverables we will be producing, and finally, our timelines. First, though, I'd like to provide some context of where and how this fits within all the planning work we do. At its foundation, a CHNA provides a snapshot of health for a defined population and geographic region. For the purposes of this CHNA engagement, that means focusing on the population of residents living at or below 200% of the federal poverty level. While we have and will continue to participate in the CHA-CHIP process managed by Austin Public Health, we feel it's important and necessary to do a needs assessment and gap analysis specific to the safety net population. Our partners' community care are required by HRSA to produce an updated CHNA at least every 3 years. Their last report was produced in the spring of 2024, so as I'll show you in a few slides, this collaboration sits perfectly within their timeline. Central Health developed its first and only safety net focused CHNA in 2022 as a precursor to the creation of its current strategic plan. We see 2026 as an ideal moment to refresh this analysis to inform the development of our other planning work, such as our comprehensive master plan and updated strategic plan. So to continue on our path of system integration in 2026, we've decided to partner with Community Care to produce our first joint CHNA. This will reduce redundancies in efforts and costs, as Community Care would have needed to hire their own consultant to do a separate engagement. This will improve consistency in how we report out information to the public, and this will accelerate decision-making resources across the system and provide timely data points for our respective boards. Next slide, please. Before we get into the project scope and timeline, I'd like to review a brief snapshot of what poverty looks like in Travis County. As we have known for many years, the highest totals and concentrations of poverty are located along the I-35 corridor from Wells Branch, Runberg, and St. John's in the north to East Riverside and Dove Springs in the south. This distribution of poverty is true today, and according to our projections, will remain true 5 years from now. We also know there exist smaller, more dispersed pockets of poverty in the less populated areas of East and West Travis County. This includes areas such as Manor, Hornsby Bend, and Dell Valley in the east, and Oak Hill, Apache Shores, and Cardinal Point in the west. Finally, we are seeing a slowdown in the increase or upward trajectory of total people in poverty. This is not a reduction in total poverty, just a slowdown of the increase. This trend mirrors the county's overall decrease in population growth as more Central Texas residents choose to locate in Williamson, Hays, and other surrounding counties. Next slide, please. Another addition to our scope we are excited about this year is expanding the analysis to the 11-county Level 1 trauma catchment area. This will allow us to better prepare and predict what types of needs and demands among the safety net population in our neighboring counties we could potentially be supporting. The map on the right shows this expanded analysis area. We will, of course, provide more detailed analysis on the areas we are charged with serving. Travis County, which is highlighted in blue, and Community Care's defined service area, which is highlighted in orange. Again, this work will support the development of new and updated strategic plans for both Community Care and Central Health, and it will inform the development of a comprehensive facilities plan for our entire system. Finally, we've listed the 4 domains we'll be assessing, which are common in a CHNA, which include population health, community conditions, structural determinants, and power dynamics. Next slide, please. Next, I want to speak to our alignment with Community Care and our friends and partners in the community. As I mentioned previously, the Community Care Board voted unanimously to support this joint effort. The CHNA will be developed in a way that supports both entities' needs, including Community Care's spring 2026 HRSA deadline. We worked hand in hand with Community Care leadership to develop a scope of work for a vendor to support this project. And we are currently in the RFP process of reviewing submissions from prospective vendors. We are also engaging partners outside the enterprise to support us in this work. We've had a strong working relationship with the City of Austin demographer dating back more than a decade when Ryan Robinson held that position. In the ensuing years, they've provided us input for our demographic reports, while we've supported them when the census tract boundaries needed to be redrawn for the 2020 census. We recognize the scope of our work is different. The demographer's focus is on housing, development, and ensuring we have accurate census counts, whereas our focus is on the well-being of Travis County's low-income population. However, we are still able to provide skills and support to one another's planning efforts. The relationship with the Austin demographer continued after Ryan retired and Leila Valencia stepped into the role. Her and I were able to meet last Friday to discuss future collaborations, and she agreed to participate in our CHNA advisory board, which we were hoping will also include experts from Austin Public Health, Travis County HHS, ECHO, Integral Care, and other community-based organizations. Next slide, please. This engagement is going to be divided among 3 distinct deliverables: a qualitative assessment, a quantitative assessment, and a capabilities and gap assessment. For our qualitative assessment, we'll work closely with our selected consultant for our outreach teams, and our community-based advisory team to identify the people, communities, and areas to gather feedback from. This feedback will likely be collected through surveys, focus groups, key informant interviews, and potentially other methods deemed appropriate and effective. We will work closely with the vendor to ensure best practices for qualitative analysis and evaluation are adhered to. Our quantitative assessment is designed to provide us with data and indicators specific to the safety net population. This will include social determinants of health, analysis of where and how frequently people are accessing care, and insurance coverage data. Finally, we will also be delivering an update to our 2022 capabilities and gap assessment. Although this is not a standard component of a CHNA, for our purposes, we believe it is essential to regularly review our current system capabilities and gaps to inform further strategic planning. Next slide, please. Finally, I would like to go over the timelines for these 3 components. We have developed an aggressive timeline informed by our previous experience developing a gap analysis in CHNA. As a reminder, our targeted February 2027 rollout aligns with Community Care's strategic planning process. Regarding board updates and presentations, we have built into the RFP a midpoint update and final presentation to both boards from the vendor. Central Health staff will also be available throughout the engagement to provide progress updates as requested. So on this first phase, we plan to start the qualitative analysis and data gathering in April, and that would be a 6-month process. The analysis and synthesis of that data will run through October, followed by the development of the report, which we hope to conclude by December, followed by the final rollout of the presentation of the data. Next slide, please. For our quantitative assessment, we're going to be a little bit more aggressive. We are hoping to have the engagement started and starting the data collection in March. That would be followed up by the data gathering, the analysis, developing the report, and getting a presentation rolled out in October. The reason we are being a little bit more aggressive with the quantitative data is so that we can get in support of the comprehensive facilities planning process as soon as possible. Next slide, please. And finally, our capabilities and gap assessment will follow the same timeline as the qualitative assessment, with the expected final rollout in February of next year. With that, I'll pass it back to Yvonne.
Hello, I appreciate the opportunity to just go over a bit from the Community Care Board's perspective, that their endorsement of the joint needs assessment. I think what's really important about this approach that we're taking is it really takes a larger viewpoint of what the needs are of the community. Service area is one of the key elements from our obligation to the health center program and the federal requirements. So it continues to monitor how the service area is evolving. And what the needs might be changing related to both clinical drivers and non-medical drivers, economic drivers, as well as obviously we know housing and food and those types of things. So having this more broad approach to the needs assessment meets our regulatory requirements, but more importantly, it helps us make good strategic decisions over services and then what our key partners will be needing during this period of time, so we understand more effectively how we're making these decisions. And I think the last thing I'll say that it's really important is the hardest part is predictability about the work that we're doing. And these needs assessments, they're key components to help with making those decisions. It helps us try to understand what potential risks are occurring, but most importantly, what care gaps we may have not had line of sight on. So I do believe that this joint methodology will serve both the health center program and then obviously our larger community and how we effectively partner over that period of time.
Questions? Before you go, keep going. Let's go ahead and take a few round of questions, and I'll start with Sedora.
So it might be helpful to have for resource materials the existing CHNAs that are in place for community care, as well as sounds like Central Health has one as well, just to, because I think that gives a better visual of the extensiveness of the survey or the report. I was wondering if some of this includes the things that are under qualitative, quantitative, and gaps, and some of the issues that were addressed in the Central Health Equity Report, because there are certain issues that surfaced there that needed monitoring, and it seems like it would be appropriate for that to be a part of this assessment in some fashion. So I think that would be helpful. And then another question I have has to do with my just being new to all of this process. This is not for action. What is an RFP was issued? What is this like covered under the approved budget already? Is this under a certain dollar amount and doesn't require any kind of board action from a procurement standpoint? How does all that work? And I don't know to whom to address that.
So we will bring back before, so there is money in the budget for this work. And when there's a contract approved as part of the procurement process, we will bring, or once a preferred vendor is chosen as part of the procurement process, we would bring a contract that's negotiated back to the board for approval.
Anybody, let me just go around the room this way. Cynthia, do you have any? Dr. Martin, any questions? Chair, do you
Yeah, I
have
have
any
a
questions?
question. The backup memo from Dr. Yagoda and Tara Trower on the fourth paragraph that says, as presented, the CHNA costs will be borne by Central Health and are not part of the approved health center budget. Who is the health center? Like, I've heard two different definitions. Is it Central Health and community care, or does this just mean that community care isn't paying for it and Central Health is paying for all of it? I just kind of needed clarity.
It's the opposite. So Central Health is funding the survey itself.
So we're paying for the RFP, which is why the contract is coming to us and not to community care. Although community care is participating in it,
Includes
they're
you
not
guys.
funding it.
Yeah. Yes.
Okay, got it. Thank you.
Yeah, thank you. That's what I thought it was, but wrong.
Thank you for the presentation. It's so good to see you. In terms of on page 20 in our packet, the timeline that you have for qualitative analysis. I'm sorry, 19. So you have for the qualitative analysis that you will be collecting the data through from April through July, but you'll also be like, I think through September, but starting analysis in August. Is that correct? What the timeline that you have?
That's correct.
So is there a reason why you're not conducting analysis simultaneously?
We built in a 2-month overlap to, so yes, we will start before we're done collecting. But we want to be considerate of the resources that we're going to also have working on the quantitative assessment. So we don't want to, we want to be able to do it on a timeline. And if we have resources working on the quantitative component and then we can shift them to the qualitative, then we won't have any interruptions.
Well, thank you for that. But I also think in terms of different methodology, in terms
Sure.
of for qualitative analysis, something of significance probably be, especially to this magnitude, is more of on a grounded theory where you're simultaneously analyzing and reading the transcript, so you can alter the questions. Maybe something emerges that never didn't really come to your attention. So that is why, especially for this type, it's perhaps recommended to do it. I understand there is a lot of work in terms of reading these transcripts and seeing what emerging themes may come up, but I think it'll be better and more helpful early on than
Make the
towards the
tweaks.
end, towards your analysis. So I think especially for qualitative, quantitative, you can probably, you're still collecting the data. It's not complete for analysis, but more of a rapid analysis might be helpful as we're trying to gather more information and we can alter the questions that we're asking and build off. So that is just a recommendation that I have for you. Thank you.
Thank you. Appreciate that. And these are not set in stone. So as we work with the vendor, we can adjust to, kind of right size it to.
Yeah, I understand in terms of capacity and time, but as someone who's done qualitative, I know they're a pain in the rear end, but if we want to get really valuable insights, timely insights that can modify our guided questions, it might be helpful as we're venturing through this schna that you call it. Well, again, thank you for all your work.
Any other questions on this side? Or comments?
You're right.
This is going to be the first time we're actually going to pay a vendor to complete this work, because the last time we had it done, Central Health did it themselves, or Community Care did it. Which one? Because I can remember having a discussion about the data that we were receiving back. And there were a couple of guys who were sitting right here in this area, who were allegedly the people that were the, I guess, the demographers for Central Health that were talking to me about the significance of the data that was included in there, because I didn't necessarily agree with some of it.
So Manager
Is that
Valdez,
correct or not?
So it's kind of correct and kind of not. So may I clarify?
Please.
This is the first time that we're going to be having consultants doing a joint community health needs assessment between Central Health. And so we did have paid consultants for the community health needs assessment that we did as part of the prior strategic plan, the
Right,
healthcare
correct.
equity plan.
Yeah.
And so that is correct. And
Community care, it's always been an.
You were over there.
Yes.
You were on the community care side.
Yes, that's correct. We've always had an internal methodology. This is our first time doing this jointly, with
correct.
with the perspective of having a broader and more inclusive viewpoint related to the work we're doing together.
And in light of the fact that we've got 11 counties that we're going to be evaluating and receiving data for. Okay, is that correct?
Yeah, the catchment area is expanded.
Yes.
Yeah, so who is going to be developing the questions to be asked? I think, Maram, you asked that? Did you not ask that?
Well, she was asking for a refinement on their collection of the data.
Well, I'm asking about who's developing the questions. What questions are going to be asked? Are they going to be the generic census type questions, or are they going to be more specific to how they're living, what services they're receiving, what are their needs, that kind of thing.
Yes, absolutely. And we hope to get additional input by having an advisory committee of community members to help us make sure our paths and those type of questions that we're developing, that we're looking in the right areas.
So we're going to contract with an entity. It's an RFP or RFQ, whatever it is. And then we're going to have, on top of that, we're going to have an advisory committee made up of representatives from 11 counties who are going to sit and review the data and try and tweak it. I want to try and figure out how that works.
Probably not 11 counties. We would like someone to represent the areas outside of Travis County, but mostly, I mean, the focus will be heavily on community care service area in Travis County.
Because some of the counties that need desperate help are at least one or two of the counties that don't even provide the statistical data to the Health and Human Services Department at the state level, which is required. Because I used to attend the meetings for the region, for the Medicare region, HHSC, and like Fayetteville, I mean the county, they never submitted their data. And so I think it's important that, especially for those kinds of counties where they have a huge poverty population that have no access to services, there's no way to get transported, there's no clinic that they can go to, and they're forced to go elsewhere. Those are going to be places where we also need to pay particular attention to, because they're big zeros. So if you're going to have somebody in place who already knows that information, that regularly attends the state meetings, regional meetings, so that they can see what the deficiencies in those and the receipt of their data or lack thereof, and that they can hone in on that kind of stuff for us to be able to look at what we're going to try and take on. Thank you.
Manager Valdez, I believe that Maram has some information that can also clarify, or to your point, address it.
Well, two distinct things. In terms of analysis, usually the advisory group don't conduct that analysis.
Right.
So I just wanted to
No,
let
no,
you know.
I
So they're typically experts who do this type of
Right.
and also for questions, my expectation is that the questions that they will draft initially are evidence-based questions that have been prior studies that they can adapt and adopt to their interview questions, which is primarily an interview guide. And my hope with the simultaneously as you're analyzing these transcripts, you may need to modify or alter the interview guide. So that
right.
probably helps you.
No, I understand that perfectly.
Okay,
Because
so
I had similar questions.
that was really
4 years ago.
thank you.
Thank you.
And one
Monica-
more thing, that make sure that it's not just bilingual, but you have monolingual interviewers. Because y'all sometimes, Central Health has historically, or at least in the past with me, gotten confused as to what bilingual means and monolingual means. There have been problems. Thank you.
Thank you, Manager. All of this. Monica, are you at a point where you can wrap this one up? Because I know you still have another presentation to make. Okay, if you could please proceed. Is that completely everything? Okay, I just want to make sure that you got it all in. Well, let me compliment you on the deck that you put forward. You really streamlined it based on what I saw earlier. So thank you for doing that. It was much more readable. Thank you. Good job. Yeah. Okay, I got you on schedule. That was my whole point. Do I have another item? Let me see. Oh, shoot. Oh, okay. Gee, I thought I was on time. Oh,
The
boy.
microphone on.
Okay,
It's
okay.
30
okay.
minutes if you
It's
want to
30
cut
minutes.
it.
Okay.
short.
Okay, next item, number 3, receive and discuss an update on the implementation of the Service Delivery Strategic Plan, Healthcare Equity Information item. If you all could quickly go through it, because we're trying to stay on schedule. We have still a lot to go, and I know that people are needing to leave early tonight. So if you would, just kind of go through it real quick.
All right, so Chairman, I'll go ahead and get us started if that's okay. Managers, tonight our team will provide an update on our progress implementing the goals laid out by this board in our 7-year health equity plan. In year 3, we continue to make strong progress, and as you recall, this plan was shaped by the voice of the community engagement process, which surfaced significant gaps and unmet needs among Central Health patients and the broader Travis County community. From that input, we prioritized new initiatives aligned to the areas of greatest need. To date, we've invested approximately $110 million above and beyond capital, so that's separate from capital investments, in implementing this plan over the past 3 years. Today, the team will walk you through how those funds are being deployed, have been deployed, and the impact they're driving. But as they do, because there's a great deal of detail in your backup, I want to briefly highlight 9 bright spots that we've made so far in fiscal year 2026. So these are the data that you have not yet seen since the previous update on the health equity plan that took us through 2025. So of the 2026 bright spots, first, expanding access to primary specialty and pharmacy services. We continue to scale our specialty services. We opened our physical therapy clinic, are well underway in planning for occupational therapy and neurology services. Alongside other facilities, the development of our major new Hancock clinic is also progressing quickly, with phased openings later this year that will include HIV resources, same-day care, and pharmacy services. Second, strengthening mental health services. We're expanding our ability to meet our patients' behavioral health needs by accepting referrals from external partners, increasing permanent supportive housing resources, growing staffing at our medical respite center, and advancing a broad diversion strategy together with Integral Care and others. Third, growing surgery and post-hospital recovery capacity. We're making significant progress on the Cameron Road facility, which will expand medical respite services. We've scaled our mobile bridge clinic team, launched justice-involved health and reentry services, and we've stood up a new general surgery department. Fourth, expanding addiction medicine and care for people experiencing homelessness. As you know, we've increased our naloxone distribution program, expanded our partnership with the Sobering Center to support inpatient recovery, added medical respite capacity, and are continuing to grow addiction treatment services. Fifth, increasing access to dental care. We're expanding primary care dental services in our clinics, coordinating closely with community care on denture provision, and assessing development of an in-house oral surgery specialty line. Sixth, improving enrollment and access through technology and coordination. We're standardizing our eligibility and financial screening process across the enterprise, integrating 3 separate services into one. Integrating these enrollment systems more effectively with Epic and expanding virtual application options, offering more on-demand enrollment for unhoused patients, and enhancing translation and interpretation services. Seventh, expanding coverage benefits. We've grown enrollment in Sendero's CHAP high-risk program, added new benefits for eyeglasses and hearing aids, and are planning medication gap coverage. Eighth, addressing social drivers of health, non-medical drivers of health in new ways. We're piloting transportation options for respite residents, launching medically tailored meal delivery, operating 5 mobile food pharmacies, that's FARM pharmacies, and standing up a workforce development program that also addresses food insecurity. And ninth, finally, deepening care coordination across our system. This includes expanding our patient navigation center across all 3 organizations, exploring licensing to support in-home physical therapy, launching a new psychiatric intake process to streamline referrals to Integral Care, and more. That's a lot of progress, a lot of work, and I want to thank the team on the ground, the many hundreds of team members who are part of this work. Implementing the health equity plan is a complex challenge, and they're doing it thoughtfully and thoroughly as we continue building a comprehensive, connected health system without edges. Our goal is to keep this board informed at a strategic level on a tremendous amount of on-the-ground build. We welcome your feedback and questions, and with that, I'll turn over to the team to dive into the details. Thanks, team. Over to you.
You, Pat, and thank you, Chair May. We are going to go through this quickly, and I'm Monica Crowley, and I'm here with Cynthia Gallegos, who is our Vice President of Operations at Central Health, and Jeff Knodel, our Chief Financial Officer. Thank you for asking us to bring this presentation tonight, which is a version of an annual presentation we've been doing for the past couple of years. We're doing this presentation on progress on our strategic plan, which has also been known as the Healthcare Equity Plan, a little bit early as we move towards working with you to develop an updated Central Health Strategic Plan pursuant to the direction you provided in the resolution regarding a system transformation strategic plan. Next slide, please. Pat provided an excellent overview of the highlights of today's presentation in his remarks. So we're only going to briefly review this agenda. Today, we'd like to provide a brief overview for managers who were not here last year for this presentation on the service delivery strategic plan. As we've said, Cynthia is going to highlight some of the key accomplishments, and Jeff's going to talk about some of the estimated investments that have been made. If it's helpful for newer board members, and thank you, Manager Jefferson, for asking for a copy of the community health needs assessment that we did as part of this work. We can provide additional background on that if that would be helpful. But many of the slides that we're going to look at over the next few slides should look familiar to some of our longer tenured managers. We've kept the updated slides tonight at a very high level. We sent an unabridged version of this in the backup, and we are available to answer any questions about that, but the main part of the deck is high level today. Next slide, please. So this is just a super high level reminder around the current strategic plan. And we always want to come back to this being founded on the voice of the community. The board adopted the current strategic plan in August of 2023. It's founded on the voice of the community, ensuring patient and community engagement were the core drivers of the planning process and will continue to be that core driver as part of the system transformation resolution. We conducted key assessments to identify significant service gaps and unmet healthcare needs, which were included in the first Safety Net Community Health Needs Assessment. Then we analyzed both the qualitative and quantitative data to further identify, validate, and prioritize initiatives with the greatest community impact. And then the board adopted a 7-year phased operational and implementation roadmap, including cost estimates for how we can fund work towards addressing those identified gaps. Next slide, please. This slide should look fairly familiar to most of you. This highlights, this is the most common depiction at a high level of the gaps that were identified, and to the question that you asked in the prior presentation, Manager Jefferson, we, in our updated community health needs assessment, part of that community health needs assessment is to assess where we currently stand in work that we've done towards addressing these gaps. This gap analysis really was a key indicator at a high level of how effectively Central Health was addressing these identified community healthcare needs across the community continuum of care, from preventive to primary and specialty care to acute hospital care and to post-acute care. And just as a reminder, we identified significant, which means we were meeting less than 50% of the needs in this area, to moderate gaps, which means we were meeting between 50 and 70% of the community's needs in any of the areas, but there were moderate to significant gaps in every area. And as Pat said, we've made a lot of progress in all of these areas, and we will be excited in a couple of slides for Cynthia to share some of these key achievements and provide further detail on how we are continuing to address these identified gaps. And but before we get there, we are going to have to talk about how we have been financing these initiatives. Next slide, please. This is just at a glance view of the identified community's needs and the priority initiatives developed that were based upon these community needs. Some of the key areas include expanded access to specialty care, which Pat has talked about, expanded access to mental health services, robust post-acute care, including respite and extensivist care, primary care, including community care, HIV/AIDS programming, and pharmacy, substance use and addiction Medicare, medicine services, access to hospital care, healthcare for the homeless services, and work on social determinants of health. And now I'm going to pass it off to Jeff to discuss the phased investments.
Thank you, Monica. Next slide, please. Thank you. Excuse me. You heard Dr. Lee allude to our total budget comprises of two elements, the operating element of it, which is about 682 million, and the capital side of it. This graph shows the estimated operating expenses. The dark lines you see are the actual budget over the 7-year plan time period. And keep in mind that these amounts are cumulative. So in other words, what happens in year one, a cost that would have occurred in year one, assuming that it was ongoing, and most, if not all of these costs are ongoing, it would have carried on into the subsequent year and will continue to carry on. So as it relates to this particular chart, looking at the FY24, the estimate that we had when the plan was developed was approximately $30 million. The actual estimate is 45 million. And then for 2025, our estimate was 50 million. The actual cost came in at $110 million. And so again, the additional $15 million that was incurred in FY24 carried over into 2025. So it just kind of doing some quick math on that, the increment in fiscal year 2025 would be about $45 million. Cynthia is going to cover some of the achievements in some of the upcoming slides, but to put into context some of the cost drivers, primarily the driver of the increases related to the acceleration of services that were made per direction of the board. And some of those include establishing our direct practice, accelerated opening of medical respite, expansion of medical teams, increased investment with community care. I think Dr. Lee mentioned our surgical care service line, and then just the necessary FTEs to support those operations. Next slide, please.
I have a question.
Are you done, Jeff? After your presentation, Jeff, I have a follow-up question.
Next slide. So one of the things that we wanted to continue to bring forward, you've seen this before. It's kind of a tracker of filled FTEs and budgeted FTEs. So as it relates to the chart, there's a couple of different areas. There's admin, clinical support, and our direct practice FTEs. And you see over time, all of our breakdown by areas of those amounts. And then you see the actual FTE amounts per month that have been filled. Specifically, our workforce has scaled up significantly over the past 3 years. We've at least doubled, almost tripled the amount of initial FTEs that we started with from October of 2023. And again, we expect to still see steady ramp up and accelerated hiring throughout the progress you'll see in FY 2026 that we had budgeted 1,049 FTEs aggregately, and that we have filled 813 positions. I'm going to turn it over to Cynthia.
So Jeff,
Yes.
Chair, can I?
Yes, I'm sorry.
Yeah, sorry.
sorry.
So, Jeff, could you remind me if any of those launch are new services in fiscal year 26?
Managing with IT, could we've got about 3 other slides that Cynthia was gonna present that are specifically about new services, if there was any.
No, it is
that helps.
related. And
Okay.
so I just want to make sure that we're on the same page here. If you remember when we adopted our budget and a budget resolution, for fiscal year 26, our budget was to sustain and optimize services. And we have agreed not to expand any new services that was not budgeted. No, so we agreed to expand a service that was budgeted for fiscal year 25, what you already have budgeted, but not to expand any new services. Have you went beyond what that
No,
agreed?
we adhered to that in the adoption of the fiscal year 26 budget.
So right now, what your new services that you're gonna be presenting are services that you had planned to launch in 25 and you could not launch it due to whatever reasons? So I just want to make sure that we have that clarity because that was part of our budget resolution and what we adapted. And I understand the services, the needs, but I want to make sure that we did not move forward with initiating any new service lines or programs that we did not agree, even though it was on the health equity plan, because we had a very interesting budget last cycle. So thank you.
All right, I'll go ahead and kick us off next. Okay, yeah, we're there. Just so for those of y'all that are not familiar with me, my name is Cynthia Gallegos. I am the VP of Operations here with Central Health. I want to make sure I take a step back and explain to you all, operations is pretty broad. And so more directly, I help oversee the direct practice service lines, which include our specialty care work, our transitions of care work, our high-risk populations work, network services, as well as our mental health services. Just so you wondering why I might be here, I am really close to the work, so I might be able to help present and answer some questions that might surface. Also want to make sure I slow down and share with you all that I'm very excited to be here as somebody that is pretty closely connected to the work and who is working with the teams more directly. It's really exciting to be here to be able to help make the connection and share with you all the progress that the teams are making. Because as you all have seen, like, we're working really hard out there. Also wanting to make sure as a grounding opportunity, what you'll see today hopefully will sound familiar. That is very intentional. I think what we're hoping to accomplish is to revisit some of the structure and the foundation of what we continue to build upon. And so if it sounds familiar from an achievement standpoint or from just some of these bullets that you're seeing, that is very intentional. All right, so I'm going to go ahead and kick off with our where we were slide, really focusing on what we've done over the last couple of years. This slide is really a summary of some of the areas in which we addressed the critical gaps that Monica spoke to earlier. As you are already aware, the board adopted the 7-year healthcare equity plan, committing approximately $800 million to address the significant system gaps that were outlined in a slide previously. We expanded services with our partner Integral Care to maintain access to outpatient behavioral health. And just to give you a little bit of context there, I think historically through that partnership, a lot of the services that we offered were more, or that they offered through our agreements were more specific and catered to inpatient behavioral health, as well as medication assisted treatment services. And so we've been able to expand beyond that, specifically in the behavioral health space. We both established and increased access to psychiatric, counseling, and peer support services through our direct practice services within Central Health, as well as through our partnership with Integral Care. We launched and expanded Bridge Clinic and mobile services, really partnering with organizations such as EMS to create a walk-in model of care for those individuals that are not able to easily access primary care. The Bridge Mobile team, which is related to this, really also focused on seeing patients at sites such as 8th Street Women's Shelter, as well as Marshalling Yard in coordination with Community Care's Healthcare for the Homeless teams. We also expanded substance use prevention, including naloxone, diversion, and treatment services. I know that Pat mentioned that in his briefing, but specific to naloxone, this past year, Central Health expanded that program to prevent drug poisonings and overdose by placing 10 naloxone distribution units in the community and distributing over 1,600 boxes of naloxone. And since then, even since last year, we've grown that. Additionally, Central Health partnered with Community Care, Community Medical Services, Addiction and Psychotherapy Services, and Integral Care to increase access to medication for opioid use disorder for patients, including patients that are incarcerated in Travis County jails. We established 5 Central Health skilled nursing facility care teams across Travis County. And we developed medical assistant, community health worker, and RN education programs to support workforce development and employment pathways. Some of these were done in partnership with programs such as Austin Community College. And really emphasizing this area, these workforce development programs are strategic to meeting the needs of our organization and our community. They are helping create a pipeline of high demand roles, and they're going to help us with, the idea is to help with our retention efforts as well. And then lastly, we've strengthened care for people experiencing homelessness through mobile teams, partnerships with EMS and other community organizations, as well as through the Permanent Supportive Housing Healthcare Collaborative, a partnership that's between Integral Care, Community Care, UT, ECHO, and Central Health. So some key achievements to name, I know that Pat mentioned this earlier, but Central Health over the last several years launched approximately 30 direct practice specialties and diagnostics, significantly working to reduce wait times. And some examples of that, just for those of you all that may not be familiar, are the launching of GI services, endocrinology services. We've included podiatry, cardiology. And speaking of cardiology, I think that's one of the best examples we can bring forward. Prior to Central Health launching that clinic, patients took anywhere from 3 to 6 months in order to access cardiologist services. And we're proud to share that that particular service line currently patients are able to access within 2 weeks. We also opened 5 Central Health specialty primary and wellness clinics. That includes our East Clinic, Capitol Plaza, Rosewood, Zaragoza, Hornsby Bend, and Del Valle. And I also wanted to make sure I mentioned that we have a North Clinic that wasn't included in the slide, as well as our Clinical Education Center, our CEC Clinic, that I think we did a lot of expansion work beyond respite. And then probably one of our largest undertakings yet, this past July, we did launch our medical respite facility, which has a capacity of 50 beds. So we're currently working on moving on up there. So really exciting work. Next slide. All right, so this is where we are. This is really intended to focus on FY26 initiatives, which we are prioritizing the effort around alignment and stabilization. With our system partners, we are focusing on strengthening alignment under a shared vision, common goals, and a commitment to building an integrated and equitable healthcare system. We are expanding dialysis services, including joint planning with our contracted providers, as well as working on identifying the clinical resources that will be required for that work. And we are also addressing food insecurity through mobile food pharmacies and medically tailored meals. Medically tailored meals addresses patients with food insecurity who also have a chronic disease. The initiative provides 7 meals a week for up to 8 weeks with the goal of linking patients to SNAP benefits. We are also continuing collaborative planning around diversion, mental, and behavioral health continuum of care with key community partners. And we are streamlining business intelligence tools, AI solutions, software and communication platforms, as well as improving system interfaces and workflows, really also including patient touchpoints. And what we mean by that is as we have the patients in front of us, we really want to make sure that our processes are well established to be able to address several of their needs while we have them. We are also working on maintaining financial stewardship by aligning resources and infrastructure to sustain current services without compromising quality, access, or long-term sustainability. And a couple of achievements that we anticipate for this year include expanding access to specialty, imaging, primary care, dental, and other services through the phased opening of our Hancock Center, which is set to open late April, early May for phase 1, and then later in the calendar year for phase 2, which will include specialty care. And then expanding Sendero, CHAP, and high-risk program enrollment. And then finally, we will be conducting comprehensive facilities planning and joint planning for ambulatory alignment, expanded clinical services, which also does include cancer services. All right, next slide. So this leaves us with what's ahead. This slide is really focused on scaling and strategic growth plans for the next several years. Our plans are to continue right-sizing and optimizing services while ensuring efficiency, financial sustainability, and system alignment. One of the critical items here is noting that we've stood up quite a bit of services over the last several years, and now we need to ensure that we have the right infrastructure in order to sustain them. We plan to continue expanding our skilled nursing facility services to improve care coordination, manage higher complexity patients, and reduce avoidable inpatient hospital utilization. And we will explore a buy-build partnership option for an ambulatory surgical center, endoscopy, advanced imaging, and dialysis facilities, which will be dedicated to our safety net population. We will continue to address emerging priorities or system needs not fully contemplated in the health equity plan, including specialty care at Northview, expanded pediatric behavioral and developmental health services, while continuing to make care highly affordable. And then some achievements to call out here in the upcoming years that we are expecting are really improving access to acute hospital services, including surgical specialties, as well as a phased approach to completing Hancock, Colony Park, and Cameron Center with the goal of bringing vital services to the community. With that, I think next slide, questions.
That's your last slide? Okay, we'll take questions now. I'll start, since last time I started on that side, I'll start with Ms. Kitchens.
Okay, one question I have is that and thank y'all thank you for all the backup. It's a lot of good detail. I really appreciate the detail. My question just goes to, at one point we had talked about developing a dashboard or set of metrics that we were going to use to measure progress on the health equity plan. So I just want to understand where we are in the process of developing that set of metrics.
So we have the metrics that we had brought historically and are working now on the OKRs, the system-wide organizational key results, and also key performance indicators that will track where we are on the healthcare equity plan progress.
Yes, we remember. Okay, so I just need to understand. We said a dashboard. We said key metrics, and I just need to understand. We've been asking for that for a while. So if you could tell us when we'll get that. Yes, go ahead.
No, I have a follow-up.
Okay, yeah. So I just want a timeline for it.
Is that a question for Dr. Lee?
I don't know who that is a question
Dr. Lee,
for.
okay, I'm going to answer it.
Yes. I think at the end of this month, we will be sharing a planning timeline with the board for review and discussion. On that timeline is a proposed date for finalizing the objectives key results for FY27 and the system key performance indicators for 27. And so as an input to providing the key dashboard to the board, we have to confirm which metrics are most valuable. And so that is those two things will then allow us to build those dashboards. The board will see those KPIs coming forward. In the background, we are doing a lot of work to ensure that we can connect the various data sources across the system. Data sources at Community Care, Central Health, and Sendero are disconnected currently in various ways. We have a number of systems inside, outside of Epic and our claims processing and so on that need to come together. So we're also doing some of the engineering and infrastructure work required to present those unified statistics. So we're going to meet in the middle. If I had to guess on when we have the system KPI dashboard up and running on a timeline basis, hopefully June, if not sooner.
Okay.
But we need to first know really which KPIs are most important. And that's on our calendar for board approval coming up.
Okay, I want to make sure we're talking about the same thing, but what I'm talking about may be a subset of what you're talking about. Because I'm talking about the performance metrics for the health equity plan. Because what we did with the health equity plan, we had a set of, we had gaps and we had a set of initiatives that we were following to close those gaps. So I'm not talking about system, although I understand it might be a subset. I'm not talking about system KPRs. I'm talking about health equity plan metrics to measure progress. Does that make sense?
I think I hear you, Manager Kitchen. There's a great deal of alignment between the work we're trying to do to close access gaps and the key metrics we want to monitor as a system. So we'll make sure they align. But yes, I think I hear you.
Okay.
And that's
I want to see when you present them. I want to see how they tie back to the initiative that we're pursuing under the health equity plan.
Understood.
And that could come under your report.
That's right.
As well. I mean, to keep us abreast as you're developing and evolving it, that should very easily could be part of the report that you're giving us.
That is the intent.
Yes, but those performance metrics we need to approve as a board for our dashboard. So, but I hear you saying you bring proposed ones back to us.
Okay, my issue is an issue that we used to receive years ago, that we stopped receiving. And that was something simple, like per, let's say, our 10 or 12 or 15 various diagnoses. These are the patients that are being seen in those particular clinics. This is how many are being seen within what time frame, so that we can have a very clear picture of whether or not they're receiving services within a week, within a month, within a year. And that we used to receive a long time ago. And for some reason or other, it became more difficult for those numbers to be presented to us, because they haven't been presented to me for a long time. Monica, you know that. And so I'm still waiting for something as simple as being able to see when our patients are receiving the services, to be able to see whether or not it's on a timely basis, or are they dying before they get to see the doctor. It's as simple as that. And to me, that is something that's very basic. Every health FQHC does that when I would think when they make their reports to the provider, whoever the provider is. These are how many patients we've seen. It may not necessarily be what they did, but it's going to be within this particular department, and either cardiology or nephrology or whatever it is. That's what I'm looking for. And that's what I have yet to receive. And I'd like to know when I'm going to receive that, because that's something that the entire board should be able to see, at least on a quarterly basis, to know whether or not we are actually making any kind of indentation in closing the disparities gaps, and whether or not our patients are receiving timely services, quality services, and in what a period of time. So can somebody answer that, please?
Happy to take a stab at that, Manager Valdez.
You're the newest staff person, I guess.
I guess so. I guess so. And
you've got staff people that have been here for a long time.
So we can keep moving.
In the monthly financials that we receive from community care, there are patient visit numbers that are always reported. And
I'm sorry, because of the numbers that are always recorded.
in the monthly financials that we receive from Dr. Goda's team from CUC, there are there are patient visit counts reported every month in the CUC set of information. Similarly, in the monthly financials report on the central health side, there are patient visit counts rolled up and by specialty. What we have not been able to do is bring those together. Some of those are the same patients, the same unique individuals. And that's what I mean in terms of bringing the data sources together. And so the deduplication between these different systems should be easy, but it's not trivial for those who've done this kind of work. And we need to bring that together in the back end. A sort of critical question is actually a legal compliance question, which relates to a question Chair Rodriguez asked earlier: who is the health center? Once we kind of have clarity that together we are the health center and these are not separate structures, then we ought to be able to bring the data together. And I know our board has directed that, and we need to work through those issues. But that's what's going to require to make one presentation where we have a clean, deduplicated list of unique individuals.
I appreciate that, sir. But what I'm referring to is something as simple as each of our patients has their own number. Okay, they're not duplicated somewhere else. They have a number. And somebody should be able to tell almost immediately. The computer can do a printout that's saying, we can give you this information. This number of people within this particular department receiving, or whatever this billing was. And since we control the billings, I think through Sendero now, and we also see the patients through our clinics, I thought that would be relatively easy. And I think it is, unless maybe I don't understand how difficult your process is, your system process is. And I would like to know exactly what that is at some point in time, because I seem to have a problem with this. Thank you.
Thank you, Manager
Go ahead,
Valdez.
Ron.
Perhaps he can get that back to you.
Again,
So, yeah.
I'm waiting.
Yeah.
Well,
2 years, 3 years.
I know we get very excited. Well, thank you for that presentation. Now, one thing that I'm hoping that as we are expanding and growing, that there's an evaluation component of each of the programs that we are implementing. And what I'm seeing, I don't see an evaluation and like, okay, so for instance, I'll give you a simple example why we should be evaluating every single program and assessing.
That's right.
Is this the right service to launch? Would it have been more efficiently, financially, and capacity-wise to contract that service rather than establishing our new facility or service line? So I just fear that as we are going and growing on this expedited and just growing and expanding service, that we are not pausing to evaluate the services that we are launching. Are they in the best benefit to our community? Are we even do we even have a financial sustainability plan? Like this health equity plan we have has a timeline, but has within the organization after this health equity plan fades away. Can the organization financially sustain that service plan? Can the organization have within the capacity of even, we talked about FTEs and filling these positions. I know other health centers are struggling. They're laying off individuals, and why sometimes I'm like a question, why are we perhaps in a different position than others? But that's another conversation. But to me right now, what I feel, and I think this goes back to Manager Kitchen's point, we need to evaluate every single program and provide us with that data for us to assess it. Now, what Dr. Lee is presenting, like two different things, a system-wide, but I know CUC is more on the primary care, not the specialty care. So we have control over our specialty services that we're launching. There's some of it is integrated, some of it is not, but I don't see that information readily available for us to move forward. And I am deeply concerned in a way that we are not evaluating and it's not part of our plan. And I know in terms of what metrics, there are established metrics or evidence-based metrics that we can use to assess every program, as in terms of capacity, how many patients are we seeing, how many patients, even duplicate patients, the timeline, the wait. So there are some measures that can be assessed, and usually those measures are addressed early on to take. So I'm going to pause here, and I think y'all heard my concern, and I see Dr. Schulze here as well. Well, thank you.
Good evening, managers, and great questions. A couple of aspects. I think when we go back to the slide that Monica spoke to, and the reasons we built out these specialty services, it was because there was a significant gap in care. It means we as a system were meeting less than 70% of the community need. I think one of the things we didn't know, one of the questions we asked is, for patients who need cardiology, what is the wait list? For patients who need GI, what is the wait list? Because we had contracted that service out to partner organizations, we had no information. And the information that we were getting was basically that there were no wait lists. And then we did our community health needs assessment and our gaps analysis, and we found out that there was a huge need for access to patient care. And so we started to build that. I think one of the advantages to building a system that is connected is electronic health records speak to, one clinic speaks to the next clinic within the same system. There is unified formularies. So when we prescribe a drug and the patients transition from from our cardiology clinic to our nephrology clinic, that, the care is maintained. There is a risk anytime we contract, for care outside of our system, that our patients fall through care gaps. As we undergo the establishment of a program, we are evaluating that program, and we're using clinical criteria to evaluate, that program. If a patient, let's say, has heart failure, is the patient being readmitted to the hospital more or less frequently? How is their heart failure being governed? Every clinical program is being evaluated based on clinical protocols and the quality of care for those patients. And that knowledge base is then reinvested. So it's not a random process.
Just two quick comments. One is just thank you very much for the work that you're doing. It's a lot of hard work. So I just want to acknowledge that. I think the second one is also just another comment. I don't have any questions. The other comment is that in our journey to become a system, one of the things that I'm noticing is this whole push-pull. And I'll just describe it real quickly. I think you all are working really hard, and as we push things and tell you around what we want to see, I think it's important to pull and be very intentional and specific about the systems that we have. Because in fact, in hearing you all, I loved you all buried this lead around the alignment to the system, right, and to the strategies. You need to lift that up. You are aligning to our board policies. You are aligning to our comprehensive strategic plan that we'll be having, because you're right now aligning to the equity plan. You're aligning to hopefully the comprehensive facilities plan, because you'll be doing not just workforce planning, but also facilities planning as well, even though it's not lifted up. And you'll also be aligning to the comprehensive health needs assessment as well. So you have the work and the journey, but it's lifting it up and bringing us along, because I think we're only going to move at the speed of trust and understanding. And I hope what you hear from us is that we're not understanding some of the work that's happening. So it's important to educate us, as well as ensuring that we all understand that the board's role is insight about the work you're doing, oversight over the things that you're doing, and foresight and looking to the future, as we see a very different environment than the one that supported the equity plan. Not only do we have a different community, a different environment at the local, state, and federal level as well, and now hopefully in the private sector, the philanthropy part. So I just want to make sure and lift up that thank you for the work you're doing, and we still have a lot of work to do to get to a journey of a system. Dr. Martin.
Dr. Martin.
Yeah, I kind of like the second what Manager Rodriguez said. There's one thing in medicine about crunching numbers and seeing lots of people versus actually getting metrics. And one thing we've been trying to work on, is getting what is our success? And that's one thing I think, who has undetectable HIV, whose hemoglobin A1Cs are good, whose blood pressures are normal. And I think this can be done to every clinic, that we can lay down some metrics. Yes, it's great to measure the wait time, but if they're just getting churned through a system where nothing's happening, their sugars still stay horribly high, then I think we need to really focus on objective metrics that the board can understand. We saw a blank number of patients, their A1Cs met with this, the HIV clinics, we had 98% undetectable patients. Those are the metrics I think that Geronimo said that the board can really understand, because the work you're doing is incredible. And I think that it needs to be made in a way perhaps better explained, because there's simplicity. Like we saw 1 million patients, but they all left as sick as the day they walked in. And I think there needs to be a focus on that, really, about our successes. And as a medical committee, we need to really focus on setting those metrics in conjunction with CUC to then present to the board. So the understanding is what has been accomplished, which is pretty amazing. So just a comment. So thank you. Oh, one last thing about the integration of the specialty system. I volunteered at CNEASH for many years. I worked at People's, and Cynthia knows these patients are not your regular patients. Okay. You can't see, when I used to get in arguments with Charles Barnett, he said, you also see 24 people, especially at this. It's like, you don't get it. These are not your regular Westlake patients who read and, can have a car. And I think that integrating the system is invaluable. When I ran the emergency center down in Harlingen, because it was integrated, the entire system, people who were illiterate could show up to the ER, and I could see what their medicines were and what their visit was the next day, as opposed to replication, duplication. I think that's integration of the system will eventually save us so much money and really provide so much better care for our patients, because it's complicated for anyone to understand this. I think that bringing it together, I think, speaks to the patient's humanity, which they need to be treated with dignity. If some poor person goes to a Westlake cardiologist, no disrespect, they're not going to treat it the same as some other person. Whereas in our system, I think that will always occur. And I think that's going to be our focus for multiple reasons. And we should continue to push that system. Thank you.
Thank you. Dr. Brinson. He said it all. All right. And then, of course, Manager Jefferson.
And I also would like the measurements, and as you've heard before, but I want to, I don't understand the chart on page 33. That's the robust workforce needed to implement the healthcare equity plan. Are these central health employees? Because I don't think they would include community care, yet some of the achievements and where we're going and all that have more of the community care and other, system is being referred to, all wrapped up. So I feel like we need to keep, apples to apples, because it's confusing. And then, by the way, I do not know what's wrapped up in healthcare operations and support versus, administration. I think I can figure out direct healthcare services, I think, but I don't know what's in that. But it's kind of troubling because, I don't know if our goal is to hire a bunch of people. Our goal is to be effective in treatment and reducing whatever goals that are set forth in the strategic plan.
So thank you for the question. First of all, it is just Central Health specific only. As far as this table here on the FTEs. Secondly, this chart kind of originated from a board request, that where are we at on FTEs? Can you show us the status? And so what we've done is we've broken them out by categories and measured over time our progress on it. So we're trying to respond to inquiry from the board. And then I just lost my train of thought. I was going to answer your last question. Oh yeah, the clinical support. Sorry. So that is it's all clinical support. It's things like eligibility, IT, anything that helps support our clinicians. That's probably an easier way to work backwards. Generally, our clinician, our direct practice cost, or providers. advanced practice practitioners, and then RNs. Anything that requires a license. Any other thing related around the clinical support is generally something that supports that. And then admin, of course, we find that as, I think you said you find that as things like finance strategy, just kind of corporate overhead departments. So it's everything else in the middle of that. Thank you.
I have one more
Thank you.
question.
I have one more.
Oh, Amit,
Wait.
and Amit,
Wait. Oh, Amit, where's Amit?
is he there?
Amit, do you have a question for us?
No.
Yes. Good, we can hear you. No, okay. All right, thank you, Amit, for hanging in there with us. And I'm gonna go back to the room. I believe Kitchen has a question.
Yeah, just a short one.
Okay.
Just a short comment that I wanted to make. And I just wanted to say that because I'm not sure if the way that I asked my question came across this way, but I understand the work that you guys are doing, and I'm very appreciative of it. It's a lot of work, and you've made a lot of progress. So please trust that when we're asking these questions, it's not a criticism. Okay, it's not a suggestion that you're not doing what you need to be doing. It's just from our responsibility point of view, there's certain things we need to understand. So we're just trying to ask that. So I just wanted, I thought it was important, to say that because you guys are doing amazing work. And I'll try to remember to really make it clear that I get that and I appreciate it. I do think that metrics is one of the things we need from our perspective, from a board perspective, and I know y'all are all working on that. And we need to be able to understand what success is, like Manager Martin put it, metrics for success, evaluation of the programs, like Manager Musaita put it. We from where we sit, we have to have a way to understand that. So, and I'm also hopeful that Manager Martin and the medical committee will take a stab at digging in more deeply into the kind of metrics that could be useful to us, because that would be helpful. But we're just wearing our board hats, and from our board hats, we need to know that. And I would just also emphasize that it's data integration that's important, so that we have a continuum of care for patients. That is not the same as governance integration. We don't have to be the same entity from a governance standpoint to integrate our data. That's a subject for another day, and we need to talk about it more. But I just wanted to make that point. Those are two different things. So,
Thank you, Manager Kitchen. We appreciate your comments. Okay, I'm just gonna tell you, we're at 6 o'clock already, and we need to
just
move,
really
because people
quickly.
need to move on.
I concur with everything that has been said. I think moving forward, maybe perhaps we can start establishing a logic model where it establishes these metrics and we can evaluate them based on what our inputs are and outputs and short-term outcomes, intermediate outcomes, and long-term outcomes. I think measuring that, we can measure success moving forward. And again, I thank you for everything you do. And I know it's a lot, but I think sometimes this is what Manager Kitchen said, putting our board hat on and ensuring that we are doing what is right for the community. I understand we're looking at it from a different
lens.
When you can look at the same picture, two of us at the same picture, and we're looking at it differently. So with that, thank you.
Thank you very much.
One statement.
You need to get moving, girl.
And this is,
Okay, and then y'all are gonna be
thank you.
upset
Instead
that
of
we're not
wasting time,
able to
all I
leave
want to
early.
say is that I would like to also see FTEs per project, or let's say for what they're doing. Yes, if it's at all possible. So if we have somebody that's in the provider side, either like community care does with their primary care, or we have specialties that are providing services. Okay, how many staff do we have, and how many people are they seeing? Another way to look at whether or not there are some efficiencies that can be achieved, or some maybe different kinds of planning. Thank you.
Okay, thank you very much. All right, folks, this should conclude all the presentations that we have on today's agenda. I'd like to confirm the next strategic planning meeting, which will be happening on April the 8th. The location will be here. The only thing I do not have is a time certain. You will be hearing more about that as we get that together. Managers, our next central health planning meeting, like I said, will be happening on April the 8th. Oh, we'll have here at 3:30, but okay, 3:30. At this time, I'm ready to accept a motion for adjournment. Do I have any motions? Thank you. Do I have a second? Oh, thank you, Sadora. Okay, it's been moved in second that we adjourn. With that, everybody in favor, say aye, please. Aye. Right. I don't think we see anything else. Okay, so now we move on to executive committee meeting, and Mr. Geronimo, our chair, will be leading that. I believe there's food in. So you can take a real quick break and go grab a plate if you'd like.
And then we'll start when everybody
When-
comes back, yeah.
Everybody comes
Yeah.
back in.
Yeah,
I gotta
we'll
go to
just
bed.
start when, after we get food, come back and we'll start in a few minutes.
You don't need me anymore.
No.
Yeah, I told him and he's
Good afternoon. Today is February 11th, 2026, and it is 6:22 p.m. As a quorum of the committees in attendance, I'd like to call to order the meeting of the Central Health Executive Committee. As a reminder, some of our committee members may also be participating by video conference, so the staff will be managing. I lost my spot. So the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. And I'd like to announce that in order to make it more accessible to community members, we will be holding the public communication for both the Strategic Planning Committee and Executive Committee meeting at the start of our Executive Committee, which is right now. And are there any commenters signed up? And I don't believe there are. So we're going to proceed to the committee agenda. And the first item, members, is the approval of the minutes of the Central Health Executive Committee, January 14, 2026 meeting.
I move.
Is there a motion? We have a motion and a second.
Second.
And a second. We have a motion and a second to accept the minutes. All those in favor, please raise your right hand. And the motion, the motion passes unanimously. And members, because we're running a little late from our strategic planning committee meeting, we're going to go into executive session to hear from item 7 to receive an update of the Central Health Chief Legal Officer, and then we'll go back into open session. So I announce that the committee is convening in closed session to discuss agenda item 7 under Texas Government Code 551.071, and then we will be back into open session. And that is on February 11th, 2026 at 6:24 p.m. Marat? Oh, I'm sorry. Sorry. I have Marat from the motion.
I know you're always thinking about me.
Great comeback, Rob.
You are the one responsible for all the money. So.
Not plus, please, no. And take care of my own finances.
to the question that I was asking Dr. Lee is like, is there anything urgent that we need to do now? And the answer was no. There are some updates, but they can be, yeah, I got it. But we can get those at our board of managers meeting on February. So we're gonna try to get through everything else that we can. Yes, ma'am.
If possible, because I know Manager Valdez needs to leave soon. If we can take item 9 whenever when do you need to leave?
It's 10 minutes, 15, 10 minutes.
In 15 minutes?
Yeah.
In 10 minutes. Oh man.
Let me go first.
Well, if we do that, we need to go back into closed session. Yeah.
Yeah, but we need to open then close, right?
Yeah, we do. So I'm gonna it's February 11th,
You did say
2026 at 7:32 p.m. Sorry, p.m. And for those that are following us, we are now at item 2. However, due to a time scheduling issue, we're going to go back into closed session, but this time we're going to go back on item 9. So I announce that the committee is convening in closed session to discuss agenda item 9 under Texas Government Code 551.071 and Texas Government Code 551.074. And that's on February 11th, 2026 at 7:33 p.m. Oh, yeah, that's right. And that would be to deliberate and possible action on the appointment, employment, evaluation, reassignment, duties, discipline, or dismissal of one or more central health employees. So we're going into closed session. Yeah, January 11th, February 11th, 2026 at 7:33 p.m. Okay. Hey. Good evening. It is February 11, 2026 at 9:05 p.m. and we are coming out of closed session, and we are on to 11/26 at 9:05. We are entering the open session, and we're going to be doing item number 3 and then calling the meeting to an end. So we're going to ask Nakia Smith to come up and do item 3, review and discuss the compliance plan as recommended by the Chief Compliance Officer. Dr. I don't know if you have any comments or introduction.
So glad Nakia is here and really appreciate the board taking the time to engage on this topic. Over to Nakia.
All right, we
Thank you.
saved the best for last. So, good evening, Chair May and members of the Executive Committee. Thank you for allowing me to present this evening. So I don't think I've met everyone face to face, so this is my first time presenting. So I'm Nakia Smith. I'm the Chief Compliance Officer for Central Health. So I will be presenting the actual compliance plan for Central Health today. Some of you have already seen the compliance plan, and this is my opportunity to spend some time with the Executive Committee to review and then get your recommendations or your feedback on the actual plan so that we can present it to the full board for approval. So in the compliance plan, the compliance plan is in your packet. It's a very full document. So my intention was not to go over that document in detail today, but just to kind of speak high level of the changes. It actually was presented to you, I believe, last year in maybe November, December, and they held it in order for me to actually make some comments to the document. So there are some sections that I actually revised pretty heavily, and I want to focus on those today. So the compliance plan really establishes the governance framework for your compliance program. So it's our foundational document. It's the core of what our department will be working on. So it kind of sets the foundation. It's not intended to have how we'll get the work done, but it's really our structural document, and it sets the authority and how we will do our work. So it outlines reporting and escalation, how the compliance officer works with this committee. So in our bylaws, this committee is really an advisory committee to the compliance officer. So your role is really to help me build out the compliance plan. It's really an oversight body for me to work with you on fulfilling our mission of having a regulatory framework in place. And then the board's responsibility, the board of managers, they maintain ultimate fiduciary responsibility for Central Health compliance program. So this body is really meant to review and receive information. So you'll receive tons of reports from me going forward, and I'll be looking for you to kind of help me guide the work and how you speak for the board and how the board may want the work done, and then we present it to them for final approval. So the structure really aligns with the Department of Justice 7 elements of an effective compliance program and the OIG, the Office of Inspector General, and the expectations are outlined, the functions are outlined, and the area that I really wanted to focus on is governance. I know that's been a theme tonight. So governance, the plan actually clearly defines reporting relationships, what the relationship is from the Chief Compliance Officer. It sets out that the compliance officer reports directly to the CEO and the president of the company. And then it also allows the Chief Compliance Officer to integrate with the leadership team. And so the way the structure has been laid out, it allows me to integrate compliance throughout the operational areas, but then it also allows me to maintain my independence. So that's very important to make sure that the CCO has direct, unrestricted access to the board. So that's outlined more clearly in our new plan. So that's the sections that I've revised pretty heavily. And I will quickly, I'll point those pages out for you so that when you are doing your review, you'll know the areas that I actually revised. So on page 33, you'll see the compliance, governance, and oversight. That's the administrative section. It's the section that clearly aligns with the Department of Justice, how we've structured the position, the reporting relationship to the CEO, and then ultimately to the board. The other area to call out is the governance structure. So the compliance program has an internal compliance committee. It's more of an operational committee. The members of that committee are the leaders in the organization that actually do the work And then that committee rolls up to this committee, and then ultimately the responsibility to the board. So that's kind of laid out in the document. And then the other section that I wanted to call your attention to is on page 30, the chief compliance officer responsibility to the CEO. And then there's a section for board oversight. And it is tagged. It's on page 32. In your packet or in the actual presentation, I've also presented or prepared for you a reference page. A lot of questions that I receive are, what are the guidelines or what is the framework for the compliance? Where does that come from? And so I've provided for you the compliance program guidance. So free to read at your will, but I've given you the three links to the standards that actually set the framework for effective compliance program. One is from the Office of Inspector General. In 2023, they actually updated the program guidance. It had been about 10 years since they had actually updated that guidance, so long awaited. And then the Department of Justice also released an evaluation, how they would evaluate compliance programs if you were in litigation, how they look at you from a prosecutory standpoint. And then I also provided for you guidance around how OIG and the HCCA, which is the Healthcare Compliance Association, how they say that boards should work with the compliance officer. Now that guidance is kind of outdated, but it still sets the framework on why we have a board. It outlines what the board's fiduciary responsibility is to the compliance officer and to the organization. So I'll stop there and ask if there are any questions or feedback for the actual compliance plan.
Sorry for, there's two quick questions I have. One is, as the chief compliance officer, are you the point of contact for any Office of Inspector General inquiries, issues, audits?
Yes.
Both the federal and state?
Yes.
OIG?
If we receive anything from those bodies, yes. I'll be the main point of contact. I'll be leading it. There's a whole process involved if you get notification from one of those regulatory bodies, but it will begin with myself and the board and also Pat.
So we should expect updates or status reports of current OIG audits or inquiries or whatever the issues are?
Yes, as a part of the reports that you'll see ongoing, you'll see any regulatory audits, any inquiries that we receive from oversight bodies.
And then the second question I have is on page 41, you have a draft of a resolution of the Central Health Board regarding the compliance. Is that something we've passed, or is that a draft of something we need to consider?
It is something that has already been passed.
Okay.
Yes.
Thank you for that. Sorry.
Which one?
Oh, page
41.
Page 41,
Exhibit
Exhibit
A.
A, at the very bottom of the page. It shows a resolution of the Travis County Healthcare doing business as Central Health Board of Managers regarding the compliance program.
But
The reason I ask is it's not signed.
I was just going to say thank you for calling it out because I think it's important for me to add the executed copy here.
Yeah.
Remember that. I'm looking for it.
You don't have that?
Fine, I'll find
It's
it.
page 42.
Page 42?
Yeah.
So because it's not dated, one of the things, because you just made a recommendation, remember I'm getting your comment and feedback. So when we present this to the board, the full board, we can actually have them adopt this that day. But I'm not sure why it's dated 2025. I'll go back and see if we don't have a resolution, then we bring it forth for a
Yeah,
resolution.
and frankly, I think that's what this meeting is for. I think we're previewing some of the material for the Board of Managers so that we can give you some feedback and you can have the final copies available to us a couple days beforehand for folks. And I think Manager Jefferson, I don't know if you heard the clarification that they're gonna look for the updated signed resolution. The one in the backup material right now isn't signed, but we think that the board has adopted and signed it, and they're gonna look for it and give it as backup material.
Oh, yeah, okay. I'm trying
Or
to-
if we need to pass it, we'll have that ready. I think David was clarifying. Okay. Yeah, so legal's taking the responsibility for following up and doing the due diligence to figure out that.
Thank you for that call out.
Turn the back up. I want to just see what document. Which?
Yeah.
Yeah, sorry. Can I ask a question while I'm looking at it? Can I ask you a question? It's just a thought on the compliance plan that might make it a little easier. You know, the section about the board responsibilities, it just refers to Exhibit A. The board responsibilities are mentioned throughout the document in different places. And just for me, it'd be great if it's all in one spot, or if it at least is repeated in that one spot.
Gotcha.
Because it made me think when I first read it, well, what about all the other board responsibilities? But it's in there.
Exactly.
It's in there in other places.
It's spread out throughout the document, and then
Yeah.
under responsibilities and oversight, section 3.
Oh,
There's a section on page 29 of your packet. Board of Managers Oversight, and you're right, it's really small, but we can flush that section out. It refers to
yeah,
Exhibit A.
if I don't want to create a lot of extra work for you, I'm just saying that as I was reading this, at first I couldn't find, as I read it more closely, I could find the board responsibilities. I just felt like it would help to have it in one place.
That definitely makes sense. Thank you.
And then may I ask another question? So the reporting, there's lots of references to regular reporting or periodic reporting to the board. I'm thinking that we'll get more specificity than that. Is that come in a policy as opposed to the plan? Just somewhere I'm wanting to read, the report will happen, every month, not month, but every quarter or whatever it's going to be.
Yeah, so I'm glad you asked that because I'm excited. I've already been working with Perla to add all of my items for you guys on her calendar.
Okay.
So what I can do,
Okay.
so when I'm presenting an update, I believe in the maybe March meeting where I'm bringing the compliance plan and the compliance audit plan. What I can do is I can bring to you guys a copy of the reporting that the board should be receiving from the compliance officer. And in that you'll see the frequency, the actual reports, and you'll see when I plan on bringing them to the actual board meeting. But I spent like a lot of time with Perla the last 2 weeks, and I have it on her calendar. So one of the things I would ask your patients, though, is that the first year, if you just picture this as our building year, right, it'll be much smoother next year where you'll see a more of a normal cadence. So I tried to work backwards in the calendar. So some stuff the first few months are kind of clumped together, but that's not how you'll see it next year.
And I recall us having a discussion that we had asked for quarterly reports on the, yeah.
So on the calendar, you'll see quarterly, and then you'll also receive an annual. But what I'm building out with my team now is those reports that we'll have readily available. And I could just give you at a high level, you should always receive reports of open audits, any open audits that we have, internal or external from a regulatory agency, or any audits that we're performing internal. You'll also receive any hotline reports that we have, any investigations. That's the kind of reports that you'll see.
Yeah, and the hotline one will have where it went or what the resolution of it is at. With redacted information.
Let's talk about because it's usually
Sure.
high level chart,
Right.
and then if there's something specifically that I need to bring, like a significant issue that we need to discuss, we can work on that. And then you'll also see privacy and security reports, and then we have some other things that we actually handle in our department, like we handle all the insurance requests. I think it's important for you guys to see that level of work that my team is doing. We handle that for everyone. So we're working now on a report, like how do we actually take all that work and give it to the board and make it be meaningful, right? Not to just give you guys a report, but what can we do with that information?
Great, thank you. Yeah.
Then the other reference I was looking for is the policies. Because I wasn't sure if I found it because, the board approves the policies, and, we're in the middle of trying to separate policies from SOPs, operational. But But I was thinking that the compliance plan needed to either list the policies or some way help us understand which policies the board was adopting that to carry out the compliance plan. Again, not the operational SOPs, but actual board level policies.
Let me think about that because we have on it's page 15 of it's item number 15 on here. So one of the 7 elements is policies and procedures, right? And it's one of the elements of an effective compliance program. And so we manage and oversee all policies and procedures within compliance, right? And then right now we're working on how that looks from a board policy level. And my team, I'm actually working on leading that work internally.
Okay.
So I'm building out, we're developing our recommended board policy.
Right, okay,
Right,
yes.
and we're bringing that to the March committee meeting. One of the things that I think you made a good point, where do we incorporate that?
Yeah, I didn't see where it said that that the board adopts policies.
So once we have our approach to how we're gonna manage board policies, we can amend the compliance plan and include that language in here. It's just important for us to make sure that the board is all in a agreement with how we're gonna handle board policies, and then we'll add it here, if that makes sense.
Okay.
Because right now, I think the section on policy and procedure might be very high level.
Okay. Well, maybe it just needs to
Or
state.
it may not say the board approves.
Yeah, it may just need to say the board approves policies, and then later you can add the procedure for that.
Okay.
Okay, that's all I have.
Thank you. And in case as we're in year 0, it might be helpful just to inform the board about what policies that you are responsible for or implementing. It'd just be helpful to know that. In terms of context, since this is the first year.
Okay.
Members, any other questions?
For that last item, are you looking at all the compliance policies that I'm developing? Or that we have under the compliance?
Current and those that are that we need to consider.
Okay, we have that. Okay.
And just from my perspective, I mean, that's just that could be your work plan, but it's also for us eyes on the board about what our governance role in seeing what policies are there and which ones you're developing, so that we know that you all are working on those.
Okay.
Yeah. Yes, ma'am.
One last question. It also references a compliance committee charter, and that would be submitted to the board for approval.
Yes, I have the compliance committee charter.
Okay.
And I omitted that from here because I thought that it had already gone. I will bring that to do you guys want to see that before it goes to?
My question is really just when do you want us to look at it? That's really my only question.
Yeah.
I think we have another executive committee meeting before we meet in March. So I'll bring it to the March meeting.
Yeah.
Ahead of the board meeting.
Yeah. Thank you.
Oh.
Members, if there's no other questions, Nakia, thank you so much for all your work. We look forward to working with you.
Let me know if you guys have questions. This is the chart that you just asked me about.
Okay, great. Thank you. Members, if there's no other questions, I'm going to close this item, and then I'm going to ask for a motion to adjourn.
So move.
And is there a second? If there's no second, do we stay here, David, until we get a second? Who wants the second? Oh, that's one. Oh, yeah. Okay. So having a motion from Manager May and a second from Manager Martin to adjourn. All those in favor? Aye. The motion passes unanimously, and we are now adjourned on February 11th, 2026 at 9:24 p.m. Our next executive committee meeting is tentatively scheduled for Wednesday, March 11th, 2026 at 3:30 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas, 78702. So thank you all for being here.